Hello, my name is Ian Holmes, and I am an advanced endoscopist at the Oregon Clinic in Portland, Oregon. On behalf of my co-authors, I'm thrilled to have the opportunity to present our most recent publication in gastrointestinal endoscopy, entitled Prediction and Management of Bleeding During Endoscopic Necrosectomy for Pancreatic Walled-Off Necrosis, Results of a Large Retrospective Cohort at a Tertiary Referral Center. This research was completed while I was an advanced endoscopy fellow at Thomas Jefferson University Hospital in Philadelphia, Pennsylvania. Over the last 10 years, the management of pancreatic walled-off necrosis has evolved rapidly with the development of minimally invasive, step-up approaches to necrosectomy. Endoscopic necrosectomy has become a widely favored strategy due to the low morbidity and mortality associated with the endoscopic approach. In recent years, the development of novel lumen-opposing metal stents has revolutionized endoscopic management of walled-off necrosis by providing a wide diameter opening for drainage, as well as a gateway for the performance of endoscopic necrosectomy. However, bleeding remains a concerning complication of necrosectomy. Bleeding can occur from the site of puncture during cystgastrostomy or cystduodenostomy, during dilation of the tract, within the cavity due to a pseudoaneurysm or intracavitary vessel, as in these pictures, or during stent removal because of tissue overgrowth. Bleeding can occur in up to 20% of necrosectomy procedures. A variety of endoscopic hemostasis strategies have been employed for intraprocedural bleeding during necrosectomy, such as through-the-scope endoscopic clips as seen here. Predictive factors for bleeding in this patient population are unknown, and there is no agreed-upon algorithm for management of bleeding. To explore this question, our group sought to compare pre- and peri-procedural risk factors for bleeding for patients undergoing endoscopic necrosectomy for walled-off necrosis, as well as compare outcomes for patients undergoing endoscopic versus interventional radiology-guided hemostasis. We completed a retrospective cohort study of all patients undergoing endoscopic ultrasound-guided drainage or debridement for pancreatic walled-off necrosis at our center over a 6-year period. Let's take a look at our patients. 536 procedures were performed in 151 patients during the study period. Intraprocedural bleeding events occurred in 5.2% of procedures and in 11.9% of patients. There was no significant difference in age, sex, concurrent antiplatelet or anticoagulant use, coagulopathy, renal disease, or etiology of pancreatitis between patients who did or did not experience bleeding. Among the comorbidities, both thrombocytopenia and cirrhosis were significantly associated with intraprocedural bleeding. When periprocedural variables were compared, the identification of a vessel within the cavity during endoscopy was found to be significantly associated with bleeding. During the study period, our group adopted the practice of placing double pigtail stents through the lumen-opposing metal stent to keep the inner flange away from the collapsed cavity wall. Double pigtail stents were placed in 224 of 536 procedures. Placement of double pigtail stents through the lumen-opposing metal stent and the diameter of the stent did not influence bleeding risk. On multivariate analysis, identification of a vessel within the cavity was found to be the strongest predictor of bleeding. In the 18 patients who experienced bleeding, endoscopic hemostasis was attempted in 8 patients across 10 procedures. 5 were treated with clips, 1 with bipolar coagulation, 6 with epinephrine injection, and 1 with coagulation grasper forceps. 1 patient underwent band placement with subsequent brisk bleeding requiring IR embolization. 4 patients received multiple modalities. 8 patients in total were treated by IR, 7 of whom had no prior endoscopic hemostasis attempted. 2 patients died from bleeding-related complications during the study period. As shown in the blue column, patients who required an IR intervention for hemostasis were transfused significantly more blood prior to their endoscopy than patients who did not. However, there was no difference in transfusion requirements between the 2 groups after the procedure. Overall, this suggests that increased pre-procedural transfusion requirements may require earlier IR intervention. To our knowledge, risk factors for bleeding during endoscopic necrosectomy have not previously been compared. However, thrombocytopenia and cirrhosis have previously been described as risk factors for bleeding during other endoscopic procedures, so their association with bleeding during endoscopic necrosectomy is foreseeable. Likewise,
The presence of a visible vessel within the necrotic cavity is a logical risk factor for bleeding during endoscopic necrosectomy, analogous to the presence of a visible vessel within an ulcer bed. A wide variety of hemostatic techniques were used during this study. This likely reflects real-world practice, as there is considerable heterogeneity in the use of hemostatic techniques during endoscopic necrosectomy in the literature, including through-the-scope clips, epinephrine injection, balloon tamponade, bipolar coagulation, and more. The current study was not adequately powered to detect differences between individual hemostasis techniques, and more data will be needed to determine the optimal method for controlling intracavitary bleeding. Likewise, as the tools of endoscopic necrosectomy change, the bleeding incidence, risk, and treatments may also change. Thank you very much for your time and for the opportunity to share our research.